Hey, what's up, everyone? Lisa Fujioka and Dr. Eugene Kim here from The House Call, the podcast where everyday people talk to doctors and various experts to break down important health conversations into plain English.
In today's episode of Diets Suck, we're unpacking a new celebrity weight loss medication that's been all over social media and growing in the news. Today, we're joined by esteemed guest and my good friend, Dr. David Kim, a 25-year veteran in obstetrics and gynecology, currently an OBGYN at the renowned Cedars Sinai Hospital in Beverly Hills, California. He's been voted one of LA's top doctors in 2020 and 2021, and it goes without saying, he's been a doctor to many of the who's who in Hollywood. Hey, David, welcome to the show.
Great. Thank you, Eugene and Lisa. Thanks for inviting me. It's a pleasure to be here.
Great.
So, David, we've been hearing and seeing a lot about this new weight loss medication that some of these top celebrities are speculated and confirmed to be taking. So Elon Musk recently tweeted in response to somebody asking him on Twitter, "Hey, you're looking good. You're getting into shape. What have you been doing?" And he admittedly said, "I'm fasting and taking this new medication." We'll reveal the name in just a sec. And then the infamous Kardashian sisters, Kim K, Khloe K, they've been losing a ton of weight in a short period of time. And there's a lot of speculation in social media and the news that they're also on this new type of weight loss medication. So what is this medication and what do we know about it?
Well, there's actually a class of medications. So there's a new class called GLP-1 agonists, which stands for glucagon-like protein, and it's a hormone that helps regulate appetite, and it works on the brain. So this particular medication, they're injectables, and Novo makes both of the ones that are currently FDA approved on the market. One of them is a daily injection called Saxenda, and the other one's a weekly injection called Wegovy. They both have analogous diabetes indications, and that's where they first started off, and that's when they started noticing weight loss in diabetic patients. It's just that there are lower doses that were given for diabetes. So the company did studies where they kind of upped the dose and did the studies, and they found that they were losing a lot of weight on the medication. And so it's really exciting because it's completely different from any of the other weight loss medications we have, because it's not it's just helping to reset your appetite and your metabolism.
I'm really surprised to hear something I'd never heard before,
hmm
which is when
hmm
it's used for diabetes, it's actually a lower dosage than those
hmm
who are using it for weight loss, where I would just think it's actually could be the opposite because when you're diabetic, you're fighting against something that's naturally
hmm
going on in your body. But like, why is that?
Well, the endpoints, I think it's because the endpoints that were used for diabetes is looking at just controlling your glucose and your hemoglobin A1C, which is sort of a measure of how well your diabetes is controlled. And they've just been able to do it on lower doses, and it's worked great. And then people were losing weight, so that's when Novo started thinking like there's something to this, and they realized that the mechanism which was helping diabetes, which is reducing the amount you eat, and by sort of resetting your sort of appetite set point, obviously works for also for weight loss. And so they just tried to increase the dose, and they've had great success with their studies. It's just remarkable because everything before this, the FDA, they would be looking, when the FDA approved drugs for weight loss, they'd be looking for like a 3 to 5% amount over, just the control, which is like diet and exercise. And for anyone who's been on diets and exercise, which is probably everyone, it just isn't something that can last a very long time, even if you initially lose weight.
Just to clarify, when you say set point, that means like their goal, the individual's goal.
When we say appetite set point, that's just a term that's created. It's a little bit hard to explain. I think everyone has your brain kind of sets a point of the amount of weight that you're supposed to be at, and then there's sort of an appetite set point to meet that. And we don't know why exactly, but as you gain more weight, what happens is that set point just starts increasing, increasing, increasing. So I think anyone that's seen or knows that when you're eating more and more over time, you're on vacation, for 2 3 weeks, and you're having delicious food, you're eating more and more, you start to want to eat more. And we don't know that exact mechanism, but we do know that these GLP agonists kind of brings that set point down, so you feel more satiety and full, and you don't have this sort of desire to like have to eat more. So that's the way it works. And appetite is kind of complicated because there's the normal appetite that the body releases hormones for sustenance, to provide nutrition, provide metabolism for your body to run. Then there's the other type that's just for sort of satiety. And there's another aspect that's sort of hedonistic. And that's like you get a high and a joy and almost happiness from eating. And so we're not, as physicians, we're not used to distinguishing all those things. But I think on the medication, you can really start seeing how these things play out because it kind of gets rid of all that and resets it. So strangely, there's some people that get kind of a little bit sad, even though they're doing well losing weight, because they just don't feel like they don't get the high from eating and like they used to, which is for some people is a big source of joy.
David, I remember you talking to me about this class of medication months ago. And as an internist, and you're an OBGYN, and this is, for me at least, I had never, when it came to weight loss, especially weight loss medications, the history of weight loss medications in the medical and the pharmaceutical market is honestly horrendous, right? Whenever it came to weight loss and talking to my patients about that, I would immediately, they're like, I need help. I would just say diet and exercise. That's all I could say. All of the history of medications. And so for those of who does, there's this medication, especially phentermine, a stimulant that just had awful side effects. People started dying on them. There was this mitral valve prolapse that occurred, which is a condition of the heart that had pulmonary hypertension. It was terrible. And so for me, at least, it was funny when you started talking about this new class of medications. I was like, what is he talking about? And I was hoping that you could talk about, the buzz around in the medical community that exists around this class of medication that honestly, actually, especially when people start talking about, because immediately, especially for me, I literally, when I think about classes of medications, like, would this be a medication I would give to my mom? Is it safe? And maybe start talking a little bit about that in terms of the excitement surrounding this medication, this class of medications, and then the side effects of them.
Well, it's interesting. I think there's a lot of doctors who don't know about it. I mean, the reason why I started doing was because I was
Mm.
following their data from the diabetes trials, and then I was just reading up on their data on the weight loss, and I usually never prescribe weight loss medication in my practice. It was just nothing that was beneficial or useful to my patients. And then this data came out and it's so impressive. I mean, when you look at Wegovy, which is semaglutide, and that's the weekly injection, you have on average 35-pound weight loss over, like 14 months and 15% of your weight. And you're not suffering during that process. You're not feeling all this hunger while you're going through it. So it's pretty amazing. In the trials, you know, in the diabetes trials, it reversed diabetes, reversed high blood pressure, reduced cholesterol, increased HDL, which, as you know, is not easy to increase HDL. It wasn't a huge amount, but it increased it, which is remarkable. Reduced death comparatively. I mean, it's this magical drug that surprisingly a lot of doctors don't know about. So doctors do kind of know about it from the diabetes side, which is Ozempic. It's the same semaglutide, but just a little bit lower dose. But interestingly, there are patients who are on it and the doctors won't go on higher doses. They're like, oh, you're on it for diabetes, you're doing fine for diabetes, and they're stopping there, even though they might weigh, like 200 pounds. They're just not doing it. And I think there's traction growing because, remember, it's only been approved by the FDA over the past year. Saxenda has been approved for several years. That's the daily injection, so it's also works great. It's just not quite as good as Wegovy, but I use it a lot because right now it's very hard to get Wegovy. There's sort of a worldwide shortage, so I use Saxenda quite often, and almost everyone that I can get on it because it's such a safe medication. In terms of putting family members in this, I would put everyone on it. The only people you have to be sort of careful on about giving it to are people who've had prior pancreatitis, people who have multiple endocrine neoplasia, people who've had a history of medullary thyroid cancer, and pretty much, if you're listening to this podcast and you're wondering what these things are, you don't have it because it's something that if you had, you would know it. And so it's very safe. There's a lot of data just from the diabetes trials for that's been going on. There's a lot of data from the diabetics that when they've looked at it, and it's very safe. I just think the only thing of consequence is some people have, constipation and diarrhea. Sometimes some people will get some nausea, vomiting. I find most of my patients don't. But that's something that can happen. But there's ways to titrate the medication, so it's great. I mean, you can just adjust it, and then usually works out really well.
Yeah, I love what you said about, to me, this class of medications, the other effects that it have outside of weight loss. Because to me, weight is an end effect, right? And to me, that is not a great indicator of your overall health. But when you start talking about increasing HDL, when you start talking about decreasing blood pressure, when you start talking about all of, in this realm for us in this podcast, we've been talking a lot about metabolic syndrome, high blood pressure, increased adiposity. You talk about insulin resistance. It's a diabetes drug. Increasing HDL, it's low HDL, but increasing HDL and then decreasing triglycerides all at the same time. The multiple effects that this class of medication can have on metabolic syndrome and what that means for overall health and, death, it's unbelievable when you think about the effects of atherosclerotic heart attacks and stroke, cancer, when you start thinking about Alzheimer's disease, and the effects that this medication and this class of medication can have downstream for all of those debilitating conditions. That was just amazing to me. I mean, and I don't think that those studies have been hashed out yet, but I mean, it's just incredible to me.
The one thing that I've been thinking more about as I've been using this in my practice is that the conversation around weight has primarily always, mostly for most people, been about aesthetics, some judgment or value about your own character, discipline, and even with physicians, I think what's missing from this is that this is a chronic disease, and people are always trying to do things for their health, like green tea, herbs, supplements, and that, but none of those things have ever shown any benefit. And here we have a magical drug that's actually reducing death. I mean, it's incredible, and doing things that you just can't see. No medication really increases HDL. And the other thing we don't think about is it's a chronic disease that the organ that's interacting with the whole body and brain, but the adipose tissue, the fat cells, are actually an endocrine organ. We don't really think of it that way, but it's an endocrine organ that communicates with the rest of the body and the brain, but somehow it's gone haywire with people with obesity. There's some communication after that went haywire, and then as you get more fat cells or adipose tissue, there's more inflammation that's created. And so people, I have a lot of patients always coming to me about inflammation, this, inflammation, that, and they don't necessarily have inflammation. We don't have a good way of measuring inflammation, but we do know that as you gain more weight and as your risk of diabetes and heart disease and stroke increases, there is an inflammatory component of that. And what's amazing is that this medication is able to communicate with all your organs, in a sense, through the brain, to reduce that inflammation and then reduce the appetite. And again, I mean, I don't know. It's amazing. I just think it's like one of those things. I mean, I have a lot of patients always coming to me for hormone replacement therapy that are older, menopause, and it's actually increases the risk of heart attacks and stroke and breast cancer, but people still want it. And it's just amazing to me that this is something that there's all this data like proven, and safe, but it just hasn't yet been at the forefront of physicians in the medical field. I think it will be, I mean, it's been pretty new, but, I'm excited about that because there's not too often that a medication comes along that can impact, 60% of the populations. I think it's approaching 70 of the US percent population has obesity or overweight, where you can impact so many people, safely, and also improve their quality of life. It's not just, there's some things, medical things we treat like blood pressure, and people don't notice it. They don't notice that's improved their quality of life. It's just you're improving their blood pressure. But this actually improves people's quality of life. A lot of people have been struggling with weight their whole lives, and all of a sudden there's a medication that can help them without suffering, achieve what they want to achieve in their goals and positively impact their health. So, I mean, I think, you and I, Eugene, talk about this a lot, and it's incredible. But it's funny, some of these celebrities are on it, but I bet you'd be hard pressed to find anybody else out there that knows about it or that's on it.
Hmm. Yeah.
I want to double click on that. We know, and it's becoming more sort of mainstream in just sort of social dialogue because celebrities are taking it, and there's this sort of
Hmm.
rumor that the who's who have access to it, and it's dinner table talk in coastal communities. Why is that? What is the barrier right now to getting this more accessible? You talked about a worldwide shortage, and why is that? Is it the ingredients that go into the medication? Is it just the affordability? What are some
Yeah.
of the barriers?
Well, because I mean, like Wegovy has a 15% body weight loss. I mean, that's just phenomenal. Like, after that, the only drugs that, if you look at the drugs that approved, it's like 3 to 5% at the most. And Saxenda has like a 10% average percent body weight, and it's not just percent weight loss, it's inches. Like the average inches off of people on Wegovy is 4 inches off your waist. I mean, 4 inches. That's mind blowing. You just can't achieve that. So I have patients who've dropped like 3 dress sizes, and they were only a month into it. So I think part of it is that there's not very many FDA approved drugs. It's also cost several $1,000s. Wegovy's probably at least 2,000 a month, and some insurances won't cover it, especially if your employer excludes weight loss management. So most people can't afford $2,000 a month. But even if you could, you can't really get it. Wegovy was just approved this past year in 2021, so they just didn't ramp up. I mean, they weren't necessarily thinking that they just weren't preparing for this worldwide shortage, um, and so you can get the higher doses, but you just can't start people on higher doses because they'll get very sick. So the starting lower doses they're just out of. So as a result, people just can't be on it. Now, as an alternative, what people have done, some doctors will put their patients on Ozempic, which is the same medication, but has the diabetes indication. So what's been happening is that's sort of been being rated, but now diabetics are having trouble getting it for their diabetes. So for me, I just put people on Saxenda right now, which is that it's more inconvenient. It's a daily injection, but you don't even feel it. The needle's so small. So that's plenty of supply for that. It works very well, and I'm just trying to transition them after 3 months to the higher dose Wegovy. But by next year in 2023, Novo's supposed to have ramped up all the production, so it should be available. So I think most of it is just that it's a new drug in terms of indication, Wegovy. So they just didn't make a huge supply worldwide. I mean, just the whole world. Who doesn't want to lose weight? And it's because of a worldwide epidemic, and then it's just very costly. And so there's lots of reasons why people can't easily get it. But surprisingly, I'd say 2/3 to 75% of my patients insurance will cover it, and then if it covers it, it seems to be like $25 a month, so which is very, very exciting. And so certainly if you're a celebrity, you can just pay the cash for it and get it. And then probably I suspect their doctors are getting giving them the diabetic, version, which is Ozempic. But, if you're not diabetics, a lot of insurance may not cover it because you have to get prior authorization, and they want you to have a diagnosis of diabetes to be able to start the actual Ozempic, which is the same thing as Wegovy, but just different brand.
It's interesting when you bring up cost, and there's no doubt $1,000 to $2,000 for anybody is extremely expensive. But I think we've had this discussion before too about when you talk about the implications of reducing all of these other effects, and I'm just talking about cardiovascular effects, decreasing HDL, decreasing hypertension, decreasing central adiposity, decreasing metabolic syndrome, and that's just in cardiovascular. I mean, there are a host of other effects that it could have outside, especially in the OB world, infertility, polycystic ovarian syndrome, honestly, and this might sound insensitive, but this is really just a message to the insurance companies that $1,000 to $2,000 a month, you are saving so much money downstream in terms of the other effects. Once somebody has a heart attack, once somebody has a stroke, right? Once somebody develops full-blown type 2 diabetes, once somebody has a waist circumference that's in the 40 to 50 inch range, oh my gosh, I mean, the amount of cost that that patient will incur upon it is astronomical. When you start thinking about this one simple class of medication, if you start putting people on just for $1,000 to $2,000, oh
That
goodness.
just even like a 3 to 5% weight loss, aside from the medication use, just in general, can reduce your risk of dying significantly. So you don't even have to lose a lot of weight; you just lose a little bit makes a huge difference. I think they have just very smart finance people in the insurance companies. I think they know what they're doing, and I've thought about this a lot, and I think partly because on average, people only keep their insurances for under 5 years because they change employers or the employers change insurance plans. They're thinking like, we don't need to invest this money because they're not going to be with us for that long. But what's interesting is Medi-Cal covers it, which is the Medicaid for California. California always has to put their own brand on it. So Medi-Cal does cover it. And Medi-Cal, as you know, there's a lot of people when they get on Medi-Cal, they don't get off of Medi-Cal. They're on it for a much longer period of time. So I think California, the finance and bean counters were smart. And they said, well, you know what? It's worth the money. Let's just, so interestingly, if you can't afford it, like really can't afford it, and you're, on Medicaid, well, they'll pay for it. That's the interesting thing. I think it's hopefully only a matter of time before Medicare covers it. And once Medicare covers it, I think all the insurances are going to just then adopt it at that point.
So we touched upon this a little bit too. Outside of just weight loss and what we had just discussed, do you feel that there are other indications, even let's say in the OB world, for this medication?
hmm Well, I mean, yeah, I think primarily for weight loss. I have a lot of patients with PCOS, and that's just a condition. No one knows what causes it, but you have sort of an abnormal balance of your male hormones and female hormones, and it causes infertility, increases the risk of diabetes, increases your insulin in your body, increased risk of stroke, causes fertility issues. And I think in those patients, diet and exercise just doesn't work very well. And so I think this medication makes a big difference in those patients. What's interesting too is we didn't really talk about, usually when you lose weight, like especially if you're fasting, you lose not only body fat, but you lose muscle. And so your percent body fat doesn't change that much. But this medication actually disproportionately reduces your percent body fat. It's kind of, I mean, it's like the perfect it's like the perfect drug. It's bizarre. You could not have designed a better drug, and so I think it's really great for those patients. And so when I'm trying to optimally, there's patients coming to me, they say, I want to be pregnant in a year or 2 years. So you can't be pregnant on the medication. You can't be breastfeeding on the medication. And you kind of, no one knows for sure, but sort of expert opinion is you should wash out the medication, meaning stop the medication 2 months, at least for 2 months before you try to get pregnant. I think there is, we don't talk about, even OBGYNs don't talk about that much, but actually when you're obese, you increase the risk of miscarriage, complications in pregnancy, preeclampsia. You increase the risk of congenital anomalies like heart defects is the most common, and neural tube defects or spinal bifida, which is incomplete closure of the spinal cord. Now, it's still small, don't get me wrong. It's not like, if you're obese, you're going to have a baby that's going to have a heart defect, but it's much higher, like 2 to 3 times higher than it would have been if you were not obese, or even if you were only overweight and not obese. And the difference is just BMI. There's this category BMI that determines whether you're obese or overweight. And that cutoff is a BMI 30, which pushes you from overweight to obese. But, we don't talk about that so much. But when it happens to someone, they end up with a baby with, and they think partly that's because there's some nutritional processing issue where you're not processing folic acid as well when you're obese for some reason. And so as a result of that, your baby's more likely to get spinal bifida. And when it happens to that patient, it's like a really big deal. It's kind of hard to then at that point talk about, oh, well, if we had to lose weight and we had to drop a little bit more, maybe we could have reduced chances. It's not a great time to have that conversation. The other thing is, it's also harder to get pregnant when you're overweight or obese. And again, we're not yet at the point, you know how medicine is, right? I mean, Eugene, it's like things have to go through this approval process, consensus. There has to be the colleges, which each of the specialties have their boards and colleges. They kind of have to hammer it out in these national debates, and then after several years they come up with some consensus statement, which is the most obvious thing in the world that people knew 10 years prior. And that's why we don't come up with these sort of things. But really, if I were to, we don't think about tuning things up like we would, you know, I don't know, like you would maintain a car, tune it up, make it optimal for performance. And certainly if you're an athlete, you do that, but we don't,
Hmm.
as a, everyday living, we're busy, we don't think about that. But really, I try to think about that. Someone who's going to get pregnant in one,
Hmm.
2 years, I mean, there's all these tests I would do to assess, their ovarian reserve, do a genetic carrier testing to see if they're carrying any diseases, genetic diseases. And then the missing point, which is what most OB/GYNs do, but the missing point is if they're obese, is to try to get their weight optimal. You don't even have to get them thin, just trying to
Yeah.
reduce some weight. And if you can do that, and especially if they have PCOS, then all of a sudden maybe they can get pregnant on their own. And people don't think about this, but it's really
Mhm.
mentally anguishing when you have a miscarriage, and miscarriages are really common. It's like 25%,
Yeah.
up to 25% of cases. If you're a 40, it's up to 40% of the time. And everything you can do to try to reduce that risk, to not have to go through that anguish and
Yes.
have this kind of ramp up period where you're planning and you're doing and you feel good and you have energy and you're now ovulating because you've lost some weight and you have less inflammation in your body. It's a huge difference, but it's not something that is so accessible, that's in a bucket for doctors right now to be able to pull that out and say that it's not part of a checklist right now. And it may not be for another 10 to 15 years until it just doesn't, how slow things go in medicine just isn't like that. So I think that's something that really could change. And once you just start saying these things too, people are very conservative in medicine. They say, well, you can't say those things. We don't have the studies yet. Well, of course we don't have the studies yet, but that's like saying, well, we're not going to treat your, I don't know, cholesterol quite yet because we don't 100% know that it's going to 100% reduce your risk of having a heart attack. And so there's a lot of things we do in medicine for far less evidence than we have with this medication right now.
Absolutely. Sometimes you just need to do something because it makes sense.
Yeah, right, right,
And I think
right.
when you get too mired in the weeds in
Yeah,
terms of
right,
evidence-based
right,
medicine,
right,
then
right.
it's kind of analysis paralysis. You end
Yeah,
up
right.
becoming paralyzed. And in the
Yeah,
meantime,
yeah,
time is moving. You're getting older. There are these risk
yeah,
factors that we know that I want to reduce and I want to try and make you healthy. And
yeah.
so am I just going to do nothing in the meantime?
Right,
No,
right, right.
absolutely.
I wanted to uh, hear from both of you sort of your personal experience with the GLP medication. And I know just from having talked to you guys, you're both actually on it for your own personal reasons. And so, can you share like which version of the GLP you were each on and why you decided to take it? And kind of what's your result or journey thus far?
Well, the only thing that was readily available, in a sense, like I said, was Saxenda. So I was starting to try that because I was starting to give that to my patients, and I just thought, you know what, I should try this, and um, and I should try it on myself. Now, technically, you have to be a BMI over 27 with a comorbid disease, and or a BMI of 30, which makes you obese. And I wanted to try it to see how I can instruct my patients what the side effects would be like and everything else, because I'm just not that, I wasn't familiar with the medication. It just wasn't, it's like I said, it's just not, it's not yet so popular that it's being used. And, mostly OB/GYNs do not prescribe weight loss medication. So the reason why I got into it was because I could not get my patients into our weight management clinic at Cedars for all sorts of various reasons. They're too busy, or their insurance wouldn't be accepted. So I was like, do I just let people, I'm going to be doing surgery in 5 months because it takes me 5 months to get surgery scheduled. Why don't I just have them try to lose weight? They have polycystic ovarian syndrome. They want to get, pregnant year. Why don't I just try to do this to lose weight? So I started researching it more, doing it. And then I found it very easy. The side effects were I didn't have nausea. I have, there was some constipation, but otherwise I did fine with it. I kept a log, kept track, like the kind of nerdy person I am. I have an Excel spreadsheet where I monitored everything. And it was interesting. Like I found that in the first, week, you don't want to have any sweets. Within the first 2 weeks, you don't want to have You don't want to have anything outside of your normal meals, and then all of a sudden you kind of get an idea of what you need to eat and the current activity you have to maintain the weight that you're at, if that was your goal. And so for me, I've lost, I think now 16 pounds. And that's with not trying.
Wow.
Like, I'm not exercising super hard or anything. I haven't changed my lifestyle that much because I have two little girls, and anyone with kids knows it's like really hard to do anything with two kids. And but I lost 16 pounds, and it's been, I don't know, like 100 days or something, a little bit over 100 days. But I lost a good chunk of that within 2 months. And it does get a little cumbersome to keep doing daily injections. That was a little annoying, but it's not painful. But I recently just jumped over to Wegovy because now I was going to switch my patients over because it's just not realistic in terms of lifelong medication use to keep doing it daily. So I can get them on the higher dose. I've calculated mathematically what the dosage should be with the higher dose and how long to do the injection to try to approximate it. And so I'm just starting to do that, and I do it on myself. I've only been on it for like 2 weeks, but I haven't had significant nausea, probably because I titrated it to a lower dose, which is kind of complicated. It's not something you should just try at home. You can't just titrate it. Um, yeah, but actually, I found the Wegovy kicked in quite a bit, like even more so. Like the Saxenda was great, but I don't know how to explain with it with Wegovy. You just all of a sudden you just lose more weight. Like, you feel great and you lose more weight. And so it's just like, I was hanging out. I think I was telling you, Jane, I was hanging out at like 160. I was at 182 when I started, and I'd already lost like 5 or 6 pounds before I started. And I was at 182 when I started, which is kind of not the highest, but it's been kind of what I've been doing for a year, which is high for me. So I was like in a BMI 27. And then I don't know. I dropped down to 167. That was pretty easy. And that's just me eating like an egg for breakfast, a lunch, and then I just don't eat as much for dinner as I used to. That's it. I don't feel like eating snacks. But you go on vacation, you have going away dinners for people, and you feel like I have to eat, and so I'd hang out at 167. But I tell you, like 2 weeks of doing Wegovy, like I just dropped to 165, which was my goal. And so then, that's like, yeah, it's quite a bit of a drop, like over 16 pounds. And that's like, it's not a struggle, and it's easy because it's once a week. So I find it really interesting. I find it really great. And I've really liked it. And I like that I've been able to delight my patients with it, and that I've been able to contribute to their health really positively in a way that, even though they have primary care doctors, even though they have nutritionists, because we have nutritionists, Cedars, even though they have all these things that they've been doing, some of them have had gastric bypass surgery and they gained the weight back. The fact that I could do something like this and make a positive impact, it's like, and I don't personally benefit from it in any way. Eugene knows this, but we don't get paid or money because we make this. It's actually illegal for us to get any kickbacks from it. So it's just purely the fact that I can impact someone's health, and they are really delighted and happy and grateful that I'm able to help them where no one else tried. So that's not even that. What's shocking to me is that they'll say, no one has even asked me.
Amazing.
No one's even asked me about weight management. No one's even like tried to help me. And so, and honestly, they don't want to hear, well, you need to work out more, because actually some of them work out. I'm always surprised. Some of them work out like an hour a day, which is a lot, and they're still just obese. And because it's a very complicated medical problem. It is not a simple calories in, calories out. There's just a lot going on. Eugene, why don't you tell us about your experience?
It's so true. It is so much more obese. Yeah, but I would second that. Obesity is such a complex issue, and unfortunately, I literally was one of those doctors 15 years ago that said, "Oh, it's simple calories in, calories out," and I was so wrong. It is so much
Well, I
more of
was
a
like that
complex
too.
issue
Right.
than that, and
Mhm.
yeah, absolutely. And I think that with this new tool in the belt, sometimes you get criticism, that people think it's kind of almost like a moral issue, which is just so disappointing. But when you are obese and you have been living that way, it is almost like it's a life of quiet desperation. And why wouldn't you
Right.
use a tool that could be effective, and that could help you in a manner
Hmm.
that not just affects your weight? Because the weight, to me, is not an aesthetic issue. It's a health issue. It's an
Right.
issue that you can live longer and you can have a better quality of life for the rest of your life.
Hmm.
And I just, to me, that's just, why wouldn't you want to help your patients? And so, in terms of my story, honestly, for me, I this is going to sound terrible, but I kind of had the same reaction in terms of when you first told me about this class of medications. And then I started doing my own research and looking at the STEP study, looking at their data. Because there have been so many classes of medications, especially in the medicine world, that have been introduced by pharmaceutical companies. And at this point, I somewhat have kind of, in the beginning, I had a positive, but now after 10 years of practice, unfortunately, I have somewhat more of a negative view of pharmaceutical companies. And so, for me, there was doubt. Honestly, there was doubt in the beginning. But listening to you, Dr. Kim, and me knowing you as the doctor that you are, what you do for your patients, I gave it a chance in terms of just trying to see what it would be like for my own patients, and even for myself. And so my own story was that I had come up to about 220, and this was secondary to steroids for a medical condition that I have. And I was BMI over 30, and then certainly had, if you're BMI over 27 with other health conditions, including hyperlipidemia, diabetes, other conditions, you qualify for the medication. So I thought, why not? And for me, at least, it has been also. I think it just as long as everybody else in terms of the story, the weight loss has been incredible. I've always been one of those people that I diet and exercise, and I've been successful in that. But when you're on steroids, it can be very difficult. So I would say, in terms of, for me though, my story in terms of the side effects is slightly different. I know for you it's been amazing. For most people, it's been amazing. There are some GI side effects that you can have. What ends up happening is that the GI system, you eat some food and the food kind of travels down your esophagus into your stomach through your small intestine, and then you poop it out. That system can slow down a little bit.
Right.
And so sometimes you can overeat. Like what I realize is that there's a connection between the brain and the gut. And that there's a signal that occurs in terms of when you eat something, then your kind of gut expands, and then there you have satiety. You feel full. And that signal is slow in terms of, there are all these people who eat slow. They do it for kind of weight loss purposes, just for health purposes, in Japan especially, which makes sense. And now I understand that system all too, because my normal habit is I'm like a dog. And then what I realized with this new medication though is that you just, if you overeat, then the food starts to come up and then you can feel nauseous. And for me, there have been a couple times where I've felt that. But I think that just as long as you're aware of that and then your body starts to recalibrate, then my experience has been exactly the same as you, David, in that it's just, for some reason, and it's just a strange feeling, because when you go throughout your entire life that, you're always hungry, that suddenly you're not. It's like, it's
Right.
as if, and I know that
Yeah.
there's some, penetration into the hypothalamus with this medication.
Right.
It's like the signals, I'm like, I don't understand it. And there's this adjustment period of me, like, I would have this habit of
Right.
eating. And then, but then I would get to the point where I'd be like, why am I putting this in my mouth when I'm not hungry?
This leads me to my last question for the day, which is, once a patient who's on a GLP-1 medication reaches their health and weight goals, I'm assuming they're not gonna want to take this injection for the rest of their lives. What are some of the things, Eugene, you were talking a lot about habit change and lifestyle change, but is that basically what they have to carry on to keep the weight off and to keep the sustained health? What would you guys recommend, having taken it yourselves and seeing patients on this?
Well, yeah, that's a good question. So I have been, it's meant to be a lifelong drug. And when they have studies, they looked at where people were taken off of it. They give placebo. They switched them out, and patients didn't know that they had placebo. They did regain the weight back, but interestingly, they only regained about two-thirds of the weight back, which I thought was very interesting. They didn't gain the exact same weight and they didn't go over, which is really important because we all know with yo-yo diets and stuff that happens. Sometimes you gain more weight back, and that didn't happen. But for me, I try to use it as a way of the patient just determining if this is my weight goal, this is kind of what you have to eat, and this is the amount of activity you have to do. Now, the question becomes is the appetite issue becomes so strong after you stop it, and that's something that they have to sort of experiment with. And what I'm trying to do is not get them off it cold turkey, but maybe instead of weekly with the Wegovy or daily with the Saxenda, we just do it every other day with the Saxenda or every other week with the Wegovy, and that they start making fundamental changes in their lifestyle and their their diet and what they're eating. Um, and it right now it's considered to be a lifelong medication, and maybe that's what it will end up being. But I think there's also a lot of people that they can change their
For not just
lifestyles
diabetes, but for weight loss.
for weight loss, just specific for weight loss. But I think there's also a lot of people
Mm.
that can probably get to the point where they change enough their lifestyle. Because some people just have this quiet desperation and just giving up, like nothing works anyway. But I think once they see the results, I think there's a lot of people that go, okay, this is the weight think I'm healthy and I'm comfortable with. So maybe they only need to be on the medication once a month or something like that, or eventually titrate off of it completely, and they've just changed their lifestyle and they're able to maintain it. So I think there's a lot more people that are going to be able to do this with this tool than not having had it. Just trying to exercise and go on a diet and try to maintain some healthy weight, I think is not, just from all the studies, it's just not possible. It's like less than 3% of the people who can do it. And over long term, it might be less than that. Yeah.
Yeah, I would second that myself. To me, I think that the treatment in terms of when you finish needs to be tailored and individualized. I mean, there are actually some patients who don't even need to be on the full dose; they can be on half dose and still have the same effect. The decision about a lifelong treatment, because I agree with David that the condition of obesity is, especially in the medical circles, is a chronic disease, and it's not something that should be judged. It is not something. It's not a moral issue. And anybody who's lived with obesity can understand that. So it is meant to be a lifelong drug. And so I think it's important to tailor your treatment to be individualized. I could see a world in which you kind of get your goal weight and you've embedded these habits, great habits of movement into your life, of exercise. Then you kind of tailor it down to a lower dose and then come off of it and see what happens if you're able to keep that weight off. But David is right in terms of the study has shown that most people have gained some weight. But what's been great is that they didn't gain all of them. And all of the past studies in terms of the other obesity medications, there is this phenomena of a rebound where people will get even more weight after they lose. And so to me, I would second what David is saying in terms of it just needs to be tailored and individualized to you. And every patient is different. Every person is different. And I would just think of it as a tool that is now in your toolbox that is effective and that you could use to just make yourself a healthier version of yourself.
Well, thank you, Eugene, and thank you, David, for joining us and sharing not only your medical expertise, but also your personal experience and journey with the GLP-1. Certainly makes me excited to see what the future of weight loss holds, aided by this medication. Thanks for tuning in to The House Call. Make sure to like and subscribe so you don't miss out on our weekly episodes. And if there's an important health topic you want to hear more about, let us know in the comments and we'll make The House Call. Till then, take care.